Thank you so much for your patience. Clarnet is India's largest live digital CME and doctor-generated medical content platform. Our website is www.clarnet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we also have MedWiki service, which is medical Wikipedia for doctors only, that you also can use at your leisure time. We will invite all the doctors to visit our website. Now, without further delay, I would like to hand over this session to you, sir, Dr. Ragesh Gar, sir. Sir, kindly proceed with your talk, sir.
Thank you so much, madam, for the kind words. And moving towards the sequence of webinar series, interesting webinar series, we today itself has a very interesting theme and clinically very relevant. So I will request Madam Dr. Namrata Ranganath to take it further on. Madam has so many credentials, big one. I can say that she is one of the best human being and best clinician to absolutely take this further on by her expertise, by her vision, and by her knowledge. Madam is working as professor and former head at Kidwai Memorial Institute of Oncology, and she is very passionate about the various oncosurgical procedures. And salute to you, madam, and over to you.
Thank you so much, Rakesh, for such kind words. And could you change the slide, please? It's my pleasure to introduce Dr. Rashmi, our associate professor, who's been with us from last 12 years. What I could say about her, a keen learner, a good teacher, and who always wants to try new things, new procedures. And I would say that any department would like to have an associate professor like her. Over to you, Rashmi, for your talk on airway management in oral cancer surgeries.
Yeah. Thank you, ma'am, for such kind words. I'll be sharing my screen now. Yeah. Firstly, at the outset, I would like to thank Anjali ma'am for giving me this wonderful opportunity to be a part of this webinar series of SOPSI. And I would also like to thank Namrata ma'am for always being there. And I would like to also thank my institute and my present professor and head, Dr. Bibi sir, and my colleagues who directly and indirectly have influenced me and helped me in this presentation. Without much delay, let's start the lecture. Today's lecture topic is airway management in oral cancer surgeries. So this is an overview of my presentation. I'll be talking about the oral cancer, its incidence, and the surgical procedures, the airway assessment strategies, what strategies we make for it, and how do we communicate as a team, and certain case scenarios related to it in the next 40 to 45 minutes.
Meeting accepted.
So the overall incidence
Domestic
of cancers continue to rise with a predicted 30% increase annually by 2030. Southeast Asia and Asia Pacific regions.
Just hold on, Dr. Rashmi.
Yeah.
May I request everybody to mute themselves? I will request Clarnet to mute everybody now. Thank you.
Sir, I have muted him.
Thank you. Over to you, ma'am.
Yeah. So I was talking about the global burden of oral cancers. Head and neck cancer as such is in rise overall, and particularly the oral cancers. Southeast Asians and Asia Pacific regions have particularly high incidence of oral cancers. If you see this picture, you can understand that the areas with the dark blue sites are having the increased incidence of oral cancers, which includes our Indian subcontinent. So globally, oral cancer is the sixth most common type of cancer, with India contributing to almost 1/3 of its total burden. And it is the second most common country to have the highest number of cancer cases. So why are we talking about this is because as a practitioner and anesthesiologist, we have higher chances of coming across such oral cancer cases. And also they are associated with the higher incidence of difficult intubation, which is 6 times higher when compared to the general surgical population. So it is a requirement for all of us to improve our expertise in handling such cases for the better outcome, better airway outcome. So it's also said in the BENUMOF that training of physicians with alternative airway devices and techniques, including emergency invasive airway access, is not only considered essential, but expected. So coming to the anatomy of the oral cavity, it is grossly divided into anterior part and posterior part. Anterior part involves the oral cavity, which includes lip, tongue, teeth, soft palate, retromolar trigone, and the posterior part mainly includes the tonsils and the base of tongue, posterior pharyngeal wall, and the soft palate. So oral cancers, common oral cancers, as I already told, the oral cavity cancer includes cancer of lip, gingivobuccal sulcus, retromolar trigone, anterior 2/3 of the tongue, floor of mouth, and hard palate. Whereas coming to the posterior part, the oropharyngeal cancer includes base of tongue, soft palate, tonsils, and the pharyngeal wall tumors. So these patients come for a wide variety of surgical procedures, which starts from wide local excision, simple wide local excision, to major resection and reconstructive surgeries. So commando operation, we generally come across this name in the routine head and neck list, which is otherwise also called as composite resection, which includes resection of a portion of the mandible in continuity with neck dissection and the resection of the primary lesion. So the surgical procedure having the major resection requires or expects the major reconstructive procedures, and the reconstructive options range from local flaps to pedicle flaps to microvascular free flaps. So as you can see in this picture, which shows the pedicle flap, PMMC flap, and the delta pectoral. So if we can understand that it constantly expects the anesthetic management in the preoperative period, intraoperative period, as well as the postoperative period. Similarly, the microvascular free flaps definitely will give better aesthetic look, which comes along with prolonged surgical time and which expects more meticulous intraoperative management of these patients. So what are the anesthetic concerns in these patients? So securing the airway right from airway assessment and securing intraoperative airway management at extubation, postoperative care is the airway related concerns in this patient. And like any other cancer patient who is coming for the surgery, we have associated comorbidities, nutritional problems, effect of CT and RT on this patient, intraoperative blood loss, hypothermia and pain, which needs optimization in certain situations as much as possible before taking up for the surgery. And we attend to these intraoperative requirements as and when the situation arises. Coming to the airway assessment in detail, I'll be talking about them one after the other. What history which is relevant to the airway need to be asked in these set of patients? History of drooling, history of dysphagia, shortness of breath, dyspnea on exertion, exercise intolerance, hoarseness, history of snoring. If your patient is having any of these symptoms, these are all indicative of airway compromise, which means that patient is having obstructive symptom and they indirectly hint towards having difficulty in vascoventilation or difficulty in laryngoscopy and intubation. So it is worth giving some time to the patient before we induce and take this particular history from the patient. And also, we should not forget to ask or check in the PAC about post-radiotherapy, post-chemotherapy, if the patient has underwent previous surgery, or if the patient had history of difficult airway before, if he has underwent surgery, if there is any history of tracheostomy in the previous surgeries, also needs to be asked for the obvious reasons. So we have taken the history. Coming to the airway examination, clinically, what airway examinations we can do? Here are the set of examinations. I will come up one by one. Mallampatti score, this is a simple and most commonly used routinely in our clinical practice. And we know that though sensitivity and specificity is low, it definitely gives us an idea about difficult laryngoscopy and intubation. So thyromental and sternomental distance, which we commonly use, and less than 6 centimeter of thyromental distance and less than 12.5 centimeter of sternomental distance indicates anteriorly placed larynx and difficult intubation. Again, this warning sign of Delilken, which is nothing but an indirect measure of neck mobility, the neck extension at the atlanto-occipital joint and the flexion at cervical spine indicates towards difficulty in laryngoscopy and intubation. So these are the commonly used ones which I enumerated so far. Now coming to some particular tests which are not more commonly used in the recent times, but this requires certain highlight. So Greenland has done an elaborate study on different parts of laryngoscopy, like laryngoscopy, which has a static component and a dynamic component. A dynamic component of the laryngoscopy involves the assessment of submandibular space. So what exactly has it got to do with the laryngoscopy? So it has been proved that the complex of the submandibular space, which forms the anterior complex of the airway, is greatly influences the ease of intubation. The space is reduced in post-surgery scar or post-radiation fibrosis. The non-compliant space occupied by the tumor, it gives us an idea about difficulty in laryngoscopy and intubation. So this is the submandibular space, as you can see. It extends between, I'll show you the extension in the next, this one. The purple space, what you can see is the submandibular space. So it is a triangular inverted pyramid, if you can see from the picture. So mainly there are different lengths which needs to be measured. The mandibular length, the distance between the two temporomandibular joints, and the mandibulo-hyoid distance. So this exactly runs between the two temporomandibular joints, and anteriorly it is from the upper incisors of the lower jaw, and the lower posterior, the lower margin ends at the hyoid bone. So this is a pyramidal shape. The compliance of this is supposed to be assessed for our intubation assessment, for the ease of intubation assessment. So there are a number of studies which are coming up, which are telling that this compliant submandibular space as a predictor for difficult airway in airway assessment. Similarly, we also have the submental space, which is seen in this green area, which lies underneath the tongue, which has a communication between the submandibular space. Again, the submental space basically is the distance from the mentum to the hyoid bone. Certain situations where the hyoid bone is not palpable for some reason, submental space is bulged because of the obesity. It is called as positive submental sign, and it is an alternate method to assess airway assessment, a difficulty in airway assessment. So all these things which can be commonly used in our routine clinical practice in the coming days, we need little more light to be thrown in these areas for making it easy to understand and how to assess this in the perioperative period with ease. Coming to the tongue, so we are talking about the oral cancers. So if it is arising from the base of tongue or the tongue per se, there is ankyloglossia, which is nothing but difficulty in extending or protruding the tongue. A large tongue, which is relative to its size, interferes with the adequate mask ventilation. And similarly, an immobile tongue, regardless of its size, prevents successful direct laryngoscopy. So this is the classification of ankyloglossia, which is like mild to moderate, may not have much difficulty, whereas if the patient is having severe to complete ankyloglossia with very minimal tongue protrusion, which has higher chances of difficulty in laryngoscopy and intubation. So next, coming to the perioperative radiotherapy. These oral cancer patients most of the times take preoperative radiotherapy, or sometimes take radiotherapy after surgery and again come for some redo surgeries. So we need to have a proper understanding of how radiotherapy is going to affect the airway in these patients. So there are a lot of side effects which radiotherapy causes, acute and chronic, that is early and late. What we are interested in is, we have to see if the patient has got fibrosis because of RT, if the patient has got trismus, if there is a pharyngoesophageal stenosis, if there is osteoradionecrosis or kyphotic deformity of the cervical spine, which is otherwise called as dropped syndrome. So all these are going to have cause difficulty in our intubation and laryngoscopy and intubation, especially the trismus of radiotherapy, because it cannot be released unlike the trismus of oral cancers, which is caused by pain. So these are the patients. You can see the skin changes and the fibrotic changes in these patients related to post-RT. Again, coming to the grading of trismus, there are many number of classifications which are available. The most commonly used being mild, moderate, and severe, which is grade 1, grade 2, and grade 3. Like 3.5 to 2.5 centimeters is considered mild, whereas 2.5 to 1.5 centimeters is considered moderate, and less than 1.5 centimeter is considered severe trismus. So the most common bedside test or subjective test, what we do is we ask the patient to keep 3 fingers, ring finger, middle finger, and pointing finger of the non-dominant hand of the patient with wide mouth widely open as much as possible, and keep it vertically in their mouth. If they're able to do it, their trismus is not much. Severe trismus shows that if the patient's one finger also, that is a pointing finger also, is not able to be insulated. Again, we have, this is a subjective way. There are, to assess the trismus objectively, we have other modalities or other scales available in the market. Palpation of the neck is equally important. One is, if you want to identify the cricothyroid membrane for front of neck axis, and this palpation also helps you understand radiation fibrosis, what amount of surgical scarring is there, or if your tumor is extending into the neck and making it very rigid, so that whatever birth manure you're going to give is not transferred to the larynx, and how massive it is going to have an effect on the impact of airway. So though it is a simple test, if we follow it routinely, when the patient is on table, it gives us idea about how difficult our laryngoscopy and intubation is going to be. So these are the clinical tests. Let's see what imaging and endoscopy tests will give us idea about the disease per se. CT and MR images, we know that to determine the location, size, and the extent of the lesion, so we need CT and MRI images. It also talks about the relationship to midline. Particularly, this is important in base tongue lesions. If it is crossing the midline, it is very difficult to attempt intubation and laryngoscopy in such patients. And especially, as I already told, the posterior complex of the oral cavity, which includes the tonsil, soft palate, and rest of the oropharynx, which are not routinely seen by examining the oral cavity, we can have better assessment with CT and MRI images. So these are the films which show that this is the base of the tongue, which the tip only will be seen by us in the oral cavity examination. If you see, it is extending right up to the vallecula. In this also, if you can see, the exophytic base of the tongue lesion is there. Here, the lesion is extending from here to here. So we can see the extent and make our airway plans, airway management plans. Again, virtual endoscopy, this is a recently developed tool for our airway assessment, which gives us a 3D view of the airway of oropharynx till the carina and helps us make decisions related to airway management. This 90-degree endoscopy is a simple OPD technique which gives us assessment of the posterior complex of the oral cavity, which cannot be assessed by examination of the oral cavity. So it tells us about the location, size, and spread. Coming to the airway ultrasound. So which is a point of care ultrasound. It is simple, non-invasive, and valuable. There are a lot of studies which have come up which tell about the role of ultrasound in the airway management. Definitely, this is going to be the future, which has a potential first line in non-invasive airway technique assessment, which is going to be in future. So it is important for us to understand the sonar anatomy of the airway, so that we understand we understand the cricothyroid membrane, thyroid, and cricoid cartilage. How do they appear on the ultrasound? It makes us easy to do the procedures like percutaneous needle cricothyrotomy and tracheostomy, and also it helps in prediction of post-extubation stridor by assessing airway edema. So again, this is a picture where with the longitudinally placed probe on the neck, this is how the thyroid cartilage and the cricothyroid membrane is seen, and this is how the cricothyroid membrane is identified. So this one, the transverse placement of the probe on the neck. Here you have the cricoid cartilage, and you come up and see the thyroid cartilage and mark your cricothyroid. And mark your cricothyroid membrane. So we have come across, we just understood the clinical investigations, what we do, and the other specific investigations on CT, MRI. What are the unique problems in our cancer patients of oral cancers is they have limited head and neck mobility, they have limited mouth opening, they have limited upper airway open space, their anatomy is distorted, there is fixation of tissue related to surgical scars and radiation fibrosis. So after assessing all this, our responsibility is to have an airway strategy. So what is an airway strategy? It is defined as a predetermined set of sequential plans for managing failure of the previous attempts and for achieving and maintaining adequate ventilation, oxygenation, and protection against aspiration. So we make an airway strategy along with the team, that is along with the surgeon. So from the preoperative assessment till the postoperative care, we need to be in communication with the surgeon related to airway management. So what do we communicate with the surgeon? We have already assessed the airway. We can cross-check with them about the location and size and spread, vascularity of the tumor, the degree of obstruction. If the CT film is done much before the patient coming onto the table, disease might have progressed. And if the surgeon has done 90-degree endoscopy in the OPD day prior, you may get better view of the disease by communicating with the surgeon. Again, your surgeon may also be giving us an idea of how easy is the intubation, because they would have done IDL or they would have done 90-degree scopy, they can tell us about the ease of intubation in a particular case and what is the nature of airway that they require. Sometimes they will ask us to give upfront tracheostomy because of the nature of the surgery itself, and what is the duration of surgery is also needs to be discussed with them. And airway compromise at the end of the procedure, like extubation, is equally important in these patients, which all needs to be communicated with the surgeon from before. So now it is important for us, once we have assessed the patient and made an airway strategy, to keep our difficult airway cart ready. Whatever instruments we have and whatever expertise you have in your particular airway gadgets, all of them needs to be ready before we attempt difficult intubation cases. So we need to have a self-questionnaire. Have I assessed the patient's airway properly? What gadgets do I have? And can I ventilate this patient? Can I intubate this patient? What is my plan A? And what is my plan B? What is the size of the tube which I need to use and what type of tube would be helpful? And what is my rescue plan? Do I have a help in the form of senior who can come in case if I have difficulty? Similarly, this is from the National Audit Project 4, which asks us to consider all these questions before attempting difficult airway, which also has aspiration risks needs to be considered, and front of neck access, do you have access for it? And is your patient easy for extubation? All these questions needs to be asked to yourself before attempting intubation in such cases. So maintaining oxygenation to prolonged apnea time whenever we are attempting these intubations is equally important. So what is no DSAT? It is nasal oxygen during efforts at tube. So continuous oxygen from the workstation through nasal cannula during awake or paralyzed intubation attempts should be considered. If you can see, we need not have to have a high-end equipments for this. Even from machine, whatever you have, you can give the supplemental oxygen through the nares where you are not attempting the nasal intubation, so that passively patient is getting oxygen, and keep the flows at 10 to 15 liters per minute. So if you have HFNO, nothing like it, which gives us Thrive, which is nothing but a transnasal humidified rapid nasal oxygen insufflation, which improves patient's oxygenation, and the apnea time can be prolonged up to 60 minutes by giving Thrive. So now what airway techniques do we need to consider in one particular case? So this is the algorithm from our textbook of onco-anesthesia. So here, if you can consider airway management in oral cancer patients, most probably require nasotracheal intubation. So if you're considering that, what options do we have? Or if you do not have the expertise or equipments which are required for nasal intubation, you can go for upfront tracheostomy. If you're considering nasotracheal intubation, it can be done with tracheal intubation under general anesthesia and neuromuscular blockade, which can be done with direct laryngoscopy or video laryngoscopy. And if you're considering awake intubation, awake nasotracheal intubation, what are the options that we have? You can do it with flexible fiber optic scope or a direct laryngoscope and video laryngoscope. A retrograde intubation is also a technique, blind nasal intubation, and there is something called as retromolar intubation. So in the next few slides, I will be highlighting about these retromolar, blind nasal, and retrograde intubation techniques. Later, we come to the other forms like fiber optic and direct or indirect video laryngoscope. Coming to the retromolar intubation, so what gadgets can be used for this? Video stillet, or this is nothing but a video assisted optical stillet, Bonfils rigid fiber scope, or a fiber optic bronchoscope can also be used for this technique. A retromolar space is a potential space where we can place the tube when the patient is having trismus where you cannot put a laryngoscope. So you have to identify the space before, which is a space behind the posterior molar and the ramus of the mandible. So there are a number of studies which are done that retromolar intubation is used for severe trismus cases. So if you can see, the scoping may be very difficult in this patient. If you identify the space, so this can be done, as I already told, with a fiber optic or Bonfils or video stillet. The advantage of video stillet is it has a shorter intubating time, shorter learning curve, less autonomic stimulation, where the major drawback being its cost. So there is definitely, as we have seen, a paradigm shift in our airway management with the invent of video laryngoscope. We also are seeing a lot of paradigm shift in airway management with video assisted optical stillets. So again, this study tells about how the residents were trained in retromolar intubation with a video stillet on mannequins, and how their study period, how their successful intubation time gradually reduced by few attempts of attempting it on mannequin. So now we have the era of simulation mannequins where anything can be simulated in the mannequin, and all these techniques can be learned easily with the mannequins. So this is a picture of video stillet. The major advantage of it is it has a flexi tip, but this part would be rigid. We will railroad the tube, ET tube on top of it, and we will do the retromolar intubation. It can also be used for awake intubation. So there are a lot of video stillets available in the market already. Coming to the Bonfils rigid fiber scope, this has a curved tip, but the only problem is the entire unit is rigid when compared to our video stillets. So there are clinically many cases and reviews have been done where Bonfils is used for retromolar intubation. So coming to the blind nasal intubation, it is almost considered a dying art, where we started our intubation and anesthesia basically from blind nasal. And now, as I already told, with the invent of mannequins and simulation mannequins, we can easily learn this technique. And there are a lot of studies where people or the clinicians and residents were made to learn blind nasal intubation with the help of the mannequins, which is a simple technique and can be used in our routine practice where other high-end airway gadgets are not available, only with trained personnel around. And a few slides about the retrograde intubation. This technique is used again in trismus ankylosis, which as a part of post-RT or post-surgery. This retrograde intubation is a misnomer because you are going to do the procedure through the translaryngeal route. So it is otherwise better to call that procedure as a translaryngeal guided intubation. There are a lot of modifications which are used and a lot of guide wires with different varieties of guide wires which can be used in this procedure. Basically, what we do is cricothyroid membrane is punctured and a guide wire is passed through that, which comes out either through the oral cavity or through the nasal cavity, and a tracheal tube is passed over the guide wire. So it has been used for more than 50 years. And again, it requires certain amount of practice. There are a lot of papers which say that what are the different methods of guide wires which can be used for retrograde intubation. So now coming to the awake tracheal intubation, as I already told, I just mentioned about these things. Now I'm going to talk about awake tracheal intubation, which we commonly mean when we say either it is a fiber optic bronchoscope or a video laryngoscope. So what are the airway devices which are available for awake tracheal intubation? So according to that study, the fiber optic, video laryngoscopes and video stillets These are the three things which were commonly used in most of the meta-analysis, the randomized control trials. We can also use direct laryngoscope as a gadget for awake tracheal intubation. So as I already told in the previous study, which I mentioned, 12 randomized control trials were assessed, and it showed that they were all clinically comparable in the setting of awake tracheal intubation, whereas time for successful intubation was shortest with optical stellate and it was longest with fiber optic bronchoscope. So when we are talking about the awake tracheal intubation, why awake tracheal intubation in oral cancers? That is because if you go through any of the algorithms, whether it is IDA, ASA, or DAS, when we are having a difficulty in laryngoscope, the second step is always either attempt face mask ventilation or a supraglottic airway. The problem with oral cancers, most of them with extensive diseases, difficulty in oxygenation by face mask or supraglottic airway device as a fallback. So awake approach is advisable. And again, rescue ventilation or fiber optic intubation with SAD as a conduit is difficult or even impossible in these situations. That is why it is better to choose awake tracheal intubation as an option. Again, when we are doing this, so the DAS guidelines tell that you need to sedate your patient. Optimal patient is very important for successful awake tracheal intubation. You need to stop. Why S is in small letter is because sedation is not mandatory. Sedation, you sedate your patient, you topicalize your patient, you oxygenate and perform the awake tracheal intubation. So for sedation, the drugs used are ramifentanil, midazolam, dexmedetomidine, fentanyl, propofol. Again, as I said, it is not mandatory. If, according to your institutional protocol, you can follow them. I'm not going into the dose details of them. Again, topicalization of the airway can be done by different techniques like nebulization, automation, gargling, spray as you go, and by airway blocks. Oxygenation is equally important. Nasal oxygen supplementation or HFNO thrive if you have. And then with all this preparation, you're going to perform awake tracheal intubation in your patient. So before you attempt, there is something called as identification of cricothyroid membrane, as I already told in the airway assessment. This can be done with a laryngeal handshake technique, which tells about, so you are going to use your non-dominant hand and with the 3 fingers, you're going to assess the hyoid bone and slowly come down and then feel the thyroid cartilage and then feel cricothyroid, cricoid cartilage and cricothyroid membrane. This technique has been documented to be having more chances of identification of cricothyroid membrane more properly than the routine method. So the advantage of that is that it can be easily identified. The specificity and sensitivity of this identification by this method is much higher when compared to the routine methods. And routinely we need to practice this to identify the cricothyroid membrane. So, and then airway double setup or front of neck access. So when you have identified it, better to mark the cricothyroid membrane and patient's neck should be prepped. Surgical team should be present when we are inducing, and they should be ready to perform an emergent cricothyrotomy or tracheostomy if the situation arises. So again, this DAS guideline talks about the checklist for awake tracheal intubation, which beautifully explains that what all needs to be kept ready and what other airway gadgets do we have. And if your team is properly well equipped and you have communicated with the team, have you oxygenated, sedated, and topicalized your airway? Everything is elaborately mentioned here, and it is a very foolproof method of having a successful awake tracheal intubation. Coming to the procedural complication, when you have started performing, there can be difficulty because of various reasons. And if you think that if your patient is deeply sedated, try to reverse if you're having difficulty in oxygenation. And then topicalization, if you feel that it is not adequately topicalized, we can try to give more local anesthetic. And if there is, in oxygenation, you can try different routes of other oxygenation if there is an oxygenation failure in your patient. And the most importantly, when you're performing, you should know that when to stop your attempts of awake tracheal intubation. So the guideline says that limit maximum attempt of 3 should be given and 1 extra attempt by an expert in that particular airway gadget can be taken, but do not try more so that you will end up having can't intubate and can't ventilate. situation. So successful awake tracheal intubation, the requirements are optimally prepared patient and expertise in the technique. Do you have availability or access to the alternate technique, and good team? Unsuccessful awake tracheal intubation, it can happen in 1 to 2% of cases, but most of the times, because you have prepared your patient well and you prepared yourself well, it may not lead to airway rescue strategies or death kind of morbidities. So there are contraindications which you keep in mind for before you attempt. The relative contraindication being local anesthetic allergy, airway bleeding, and uncooperative patient, whereas an absolute contraindication is a patient refusal. So this is again the algorithm by Das in unsuccessful ATI. If you can see that if you are not able to perform an ATI, you either, if it is not an emergent condition where oxygenation is compromising, you can try thinking of postponing the case. If postponing is not possible, if you are having difficulty in oxygenating the patient, then think of FONA, that is front of neck access, either by directly performing the cricothyrotomy or tracheostomy, or after giving a high-risk GA if your patient is too much agitated. So now we have assessed what all different routes of airway assessments we have and airway plans, what we can make in these cases. Let us see some case scenarios. Case scenario 1, this is a case of right floor of mouth. If you can see, the patient is having a small lesion. You cannot even see the lesion here. Patient is having a good mouth opening, and ankyloglossia is also not much. So this 66-year-old patient was hypertensive, is posted for wide local excision, bilateral neck dissection, and reconstruction. So what was the airway plan in this patient? Which we planned was, tracheal intubation under general anesthesia and neuromuscular blockade. We did it with direct laryngoscopy. So our plan A was conventional laryngoscopy and nasal intubation under general anesthesia and muscle relaxation. So here the prerequisites again is you need to prepare the nose with oxymetazoline drops and lignocaine jelly, and you have to see the patency of the nostril. Then you pre-oxygenate and you can sedate your patient, give propofol, check mask ventilation, give short-acting muscle relaxant, and try attempting laryngoscopy. So we generally see the patency of the nares by seeing the CT film. And the alternate technique, what you can see is by using a spatula and asking the patient to breathe in and breathe out, you can see which nostril is more patent by seeing the fogging on the spatula. Whichever, anyways, we need to prepare both the nostrils because we may have difficulty while passing the tube. So this CT film, when you are seeing, it will give you an idea of which side of the nasal passage is more roomy, and if there is any nasal septal deviation, and if there are any spurs. So as you can see, right nasal nostril was more roomy in this patient. We put a right nasal nostril here, and we are giving supplemental oxygen through the other nostril when we are attempting intubation. So the endotracheal tube is passed through the right nasal cavity. After giving propofol and succinylcholine. After this, direct laryngoscopy was done. Cormac-Lahell, it was grade 1, and the endotracheal tube was passed through the glottis. Trachea was intubated and position was confirmed. But what is the other alternate route is, after giving scolin you do the checkscopy before you push the ET tube through the nasal cavity, because once you push the nasal cavity, ET tube through the nasal cavity, there are chances of bleeding, and which may obscure your glottic view. So some consultants also use the technique that first you do checkscopy after scolin, and then you have the idea of how is the glottic opening, then you push the ET tube through the nasal cavity. So what if the plan A is failed? So in this case, if there is any unanticipated difficulty in laryngoscopy and intubation, either you try to bring the patient out of anesthesia or postpone the case. You can, of course, always attempt a fiber optic intubation or an awake intubation with or direct laryngoscope in case if you have that. Or if any of the failures are there, finally, we have to go for front of neck access, that is a surgical airway. The practical difficulty in these cases, which are like common for any nasotracheal intubation, it can be difficulty in passing the ET tube, negotiating the ET tube through the nasal cavity, or there can be bleeding. In these cases, what we do is we secure the oral airway, and then give the long-acting muscle relaxant, because you already have visualized the glottic opening and you know that you will be able to manipulate and push the nasopharyngeal nasal endotracheal tube through the glottic cavity, the glottis. And then if there is a difficulty in negotiation of the nasal cavity, what we routinely do is we either push a gum elastic bougie through the nasal cavity or a rails tube, and we will railroad the ET tube over that. And then once the ET tube is seen in your pharynx, we will try to put a bougie to the oral cavity if it is an anticipated difficulty. Otherwise, you push the ET tube, you take out the bougie and the rails tube, and then push the ET tube which is coming from the nasal cavity. It may be little difficult to understand as I'm explaining without pictures. When we discuss, maybe we will have a better idea of how do we do it. Coming to the second case, this is a CA buccal mucosa. As you can see, there is a lot of infiltration into the surrounding structures and the patient is having trismus. She's a 47-year-old case of CA buccal mucosa and she's posted for composite resection and reconstruction. And this patient is post-chemotherapy. She has taken 2 cycles of paclitaxel and carboplatin. Again, coming to this algorithm, if you stick to the algorithm, this patient we tried intubating with the flexible fiber optic bronchoscope. So plan A was awake fiber optic intubation. Again, you do that sedation, topicalization, oxygenation, and perform. You prepare the nose, then topicalize the airway. Commonly, what we do in our institute is nebulization at 2% lignocaine for 10 minutes, followed by transtracheal injection of 2 ml of 2% lignocaine and spray as you go technique. So you can see that we are also trying to palpate the cricothyroid membrane, that is by 3-finger technique, which is the laryngeal handshake technique. And we are topicalizing the airway, and here transtracheal injection is being given. So team coordination is very important for success of any awake intubation. So endotracheal tube, after it was secured, it is connected to the circuit and cuff is slightly inflated. You see the ETCO2 tracing. This is called as double technique. That is the 2-sign technique, where you see the ETCO2 tracing on the monitor and also you see your endotracheal tube in the trachea when you are coming out either with the direct laryngoscope or fiber optic scope. After that only you give the sedation or relaxation for your patient. So do not attempt giving propofol and muscle relaxation before you see ETCO2 tracing, which can have an unsuccessful awake tracheal intubation. Coming to the third case, this is a CA mandible with restricted mouth opening. Patient is having a painful trismus. You can see that the mouth opening is less than 2 fingers. He will be difficult mask ventilation and there will be difficult laryngoscopy because the bony structures are also involved. So if you stick to the algorithm, what we can do in this patient, see what we tried was direct laryngoscopy. It was not awake and it was not under muscle relaxation. We just did it with propofol sedation. So I'll come into the details of it in the next slides. So our plan A was checkscopy with video laryngoscope under propofol sedation. So you cannot call it completely awake, but you cannot call it as completely paralyzed. So the hypothesis in this case, what we made was with propofol sedation, the mouth opening may improve because patient is having painful trismus. So short-acting muscle relaxant was given after video laryngoscopy. When you're with your video laryngoscopy, you're able to see the glottic view. Then we proceed with short-acting muscle relaxant like scolin and then proceed with nasal intubation. At the same time, with video laryngoscopy, we are not able to see the glottic view. Our next further management would be different, like bring out the patient off the propofol sedation, try fiber optic, or you can straight away go with front of neck access. So if you can see here, what we did was pre-oxygenated the patient, and here he is doing checkscopy after propofol. Once we saw the glottic openings, he will bring out the scope, and again we will mask ventilate and give succinyl choline. After succinyl choline, which you can see, I will play both the videos together. He is attempting nasal intubation. So ET tube in this case easily passed through the nasal cavity and it is at the glottic opening. So we used a cuff inflation technique because it is not getting negotiated. But with cuff inflation, also it is at the glottic opening, it is not moving further. We tried twisting the tube towards the one side, which is also not helping. Here, if you can see, our technician is trying to flex the patient head. After that, the ET tube went inside the glottic opening. So what difficulties in pushing the ET tube at glottis? So either you try to rotate the ET tube, cuff inflation technique can be used, or using a preformed endotracheal tube. You make the shape of the ET tube preformed, or use a Magel's forceps. In this case, we did not use Magel's. With flexing the patient's neck only, we were able to negotiate the glottic opening. These are some of the simple tips which you can use in difficult nasal intubation cases. So cuff inflation technique, as I already told, by inflating the cuff, the orientation of the cuff tube will change and it may direct towards the anteriorly placed larynx. So these cases, I'm not going to go into the details of anesthetic management. I will just tell you, so this can be discussed later in the discussion part, that what will be the route of ventilation and airway securing plan, and while we discuss the cases. This is a case of CA lip, which is fragile, which is patient will have difficulty in mask ventilation, and it need not be a difficult laryngoscopy because it is very anterior. Coming to the CA lateral border tongue, again, it is very fragile and it will bleed on touch. It will be definitely a difficult case for laryngoscopy. CA base of tongue, which requires special mention because the extent of the disease is not seen for us. It is mainly we need to go through the CT and MRI images to understand the extent of the disease, and it bleeds on touch. It is difficulty in mask ventilation, difficulty in laryngoscopy, as well as intubation. Again, this post-surgery patients which can come for any of the redo surgeries, we need to have a airway strategy before we take them up for surgery. So now, what is the rescue airway plan? In case if our airway awake tracheal intubation fails, so as already told, that you have to go for front of neck access, which can be scalpel cricothyrotomy or needle cricothyrotomy, depends on the expertise you have. If you have a surgeon along with you directly, you can go with tracheostomy. Jet ventilation is used for oxygenation in case of failing oxygenation to the patient. So this is all the securing, different methods of securing the airway. Intraoperatively, what challenges do we face? So because of the surgical field requirement, our ET tube generally is not seen for us. So it is important for us to be constantly vigilant, and the breathing circuit disconnections can happen. So it is important for us to use the non-kinking endotracheal tubes and minimize the pressure when you're securing the airway with the plasters to avoid ulcerations in the nasal ala or the buccal commissure. Again, in some of the surgical procedures, what can happen is tracheostomy can be done in the middle of the surgery as the situation demands for it. Then at that time, we need to be in constant touch with the surgeon. We need to pull the oral or the nasal endotracheal tube out and give access to the trachea where they're putting the incision, and the tube will be passed, a flexometallic tube will be passed through the tracheostomy opening by the surgeon, and it will be secured through the stoma of the into the trachea. So coming to the extubation, so what we need to always keep in mind is extubation is always elective process, and postponing extubation by few hours or some days may be most appropriate in most of this oral cancer cases, considering that they have major reconstructive surgeries and airway manipulation. So delay allows airway edema to resolve, and this increases the chances of successful extubation in the coming day. So we have again extubation guideline by IDA. It says that if your patient has 4 Ds and 3 Ss, in most of the CA oral cancer cases, we have difficulty in mask ventilation, intubation, re-intubation, and also there is a surgical airway compromise. So our patient definitely has these 4 Ds and 3 Ss. So if there is the situation, what we need to do is we have to have a plan, extubation plan over airway exchange catheter, or you delay the extubation. These are the options we have for maintaining the airway in the postoperative period. Again, coming to the DAS guidelines, there is something called as at-risk algorithm. And again, in this at-risk algorithm, our patients of oral cancer surgery, post-surgery falls into the advanced airway techniques or postponement of extubation or tracheostomy as their airway extubation planned. So what are these at-risk extubation? Again, our patients are having pre-existing airway difficulty and again perioperative airway deterioration and restricted airway access because of the surgical flaps. So airway exchange catheter assisted extubation. So patients for whom re-intubation is likely to be difficult. So this is tried and versus delayed extubation. So we should always consider which one is better, in particularly at the end of the surgery and being in communication with the surgeon, we need to decide which one is better for the patient. So again, there are a lot of studies which have told that, this is replacing the overnight keeping of the endotracheal tube is replacing the requirement of tracheostomies, and overnight keeping the tube has having good patient compliance in terms of early recovery and early discharge. So now we have managed the airway in the OT. Coming to the post-op airway. So overnight ventilation, when I say overnight ventilation, which mostly means that the ET tube in situ with spontaneously breathing patient. And this is followed by extubation the following month. And the extubation is done following morning in the expected norm in most of these oral cancer cases. So postoperative airway management should be guided by local protocols and whatever is the institutional protocol, which we generally follow. So why it is important to keep the endotracheal tube in these patients is because these patients at any time can return to the theater because of neck hematoma, because of flap failures or fistulas and airway management issues. So it is more safe to keep the endotracheal tube overnight in these patients. And whenever they have kept the endotracheal tube overnight, it makes sense to monitor the ET tube with continuous capnography to avoid dislodgement and displacement. So post-op airway management, if we have decided to keep the endotracheal tube, you can see that they're all ventilated spontaneously with the TPs in situ. So we need to take care of their sedation. We need to take care of their oxygenation, humidification, and care of endotracheal tube. Care of throat pack, if there is any. If you can see, the throat packs are secured with the plaster, with a small string, and then plan extubation. So some patients may also require elective tracheostomy. Let us see which all patients require elective tracheostomy. So the decision to perform tracheostomy is decided by the extent of the airway compromise at the end of the surgery and the likelihood of postoperative airway deterioration. And do we have the ability to rescue the airway? If you feel no, then that patient is a candidate for surgical tracheostomy. And the extended duration of significant airway compromise, if we are expecting in that particular patient, he is a definite candidate for surgical tracheostomy. So again, the surgical tracheostomy, what are the benefits? Benefits are it gives effective bronchial toilet because the tracheostomy tube is much smaller and there is a reduction, there is a reduction in the dead space, which assists in early weaning from the mechanical ventilation in case if the patient is on mechanical ventilator. And definitely the surgical tracheostomy is not without the risk being hemorrhage, obstruction, displacement, stomal recurrence, or poor healing after radiotherapy. So we should always weigh the pros and cons before considering any airway management strategy. So to conclude, as a team, sharing airway is, airway is shared by the surgeon and the anesthesiologist from intraoperative period till the end. Be aware of the continuous control of difficult airway. Keep in mind unavoidable episodes of ventilatory insufficiency which can arise anytime. Ensure alternate methods to guarantee adequate gas exchange, and always keep your calm in any emergent situations, and you should know to call for help. To summarize, superlative surgical outcomes rarely occur by chance, but are the product of two factors, that is active perioperative optimization of the patient and consistent surgical and anesthetic team approaches to the procedure. To achieve this goal, active collaboration and communication with anesthesiologists, surgeons, and the other team members like technicians is equally important throughout the perioperative period. Thank you.
Thank you, Rashmi. You can stop sharing your screen. And what a comprehensive presentation. And exactly an hour, I should say. So let's take the questions. The first question being, Rashmi, how can we differentiate between trismus due to pain and that will not be relieved under GA?
See, we can ask the patient, ma'am, if the patient is having pain, when we ask the patient to open the mouth, if he is having pain. So history by the patient should never be neglected. So that gives a very good indication about if the patient, if it is due to pain or not. The second one is if it is post-radiation fibrosis or post-surgical. So it is again history related. Like you're going to ask if the patient has taken radiotherapy before or if the patient has underwent surgery before, which tells us about whether the trismus is because of pain or whether it can be released by propofol sedation or not. Sometimes our assessment can go wrong when we think that we will be able to do scopy. When we do the check scopy, we would not have been able to proceed. So this also has happened. It is mainly the discretion by your clinical knowledge, I would say.
I hope Vibha got the answer. Basically, it is what Rashmi said. Sometimes when we are doing fiber optic intubation, sometimes we just nebulize the patient. And after nebulization, we see what mouth opening was before and what has happened after nebulization is a drastic change. So there is no certainty with which we can say that it is because, yes, history is the most important. And sometimes when we are doing check scopy, just the pain is relieved, we can differentiate that time also when we are in doubt about it. Another question by Vibha is, what precautions are required for patients with parapharyngeal masses? If Vibha, you can clarify what exactly you want precautions in airway management, depending on where it is. Rashmi, would you like to take it, or you want to clarify?
Sorry, ma'am. Come again. I didn't understand the question.
What precautions are required for patients with parapharyngeal mass?
What precautions? Yeah, see again, it goes mainly by imaging, because assessment wise, we will not be able to assess much of the posterior pharyngeal wall tumors. So we have to rely on CT imaging or MRI imaging when it is a posterior pharyngeal wall tumor. And we have to discuss it with the surgeon about the extent of the disease and the type of the tumor as such. So, and also see 90-degree endoscopy can throw some light regarding its extent, which we can be able to see through the endoscopy videos and make our airway plans. In case if the posterior pharyngeal wall tumor is so huge that it is abutting the base of tongue, or it is abutting, so history-wise, patient will be having definitely dysphagia, hoarseness of voice will be there for that patient. Patient can have breathlessness because the cardiopulmonary reserve is compromised. So all these are indirect hint towards obstructive symptoms and what airway management plan we need to make in such patients.
All right, Vibha, as you said, they may seemingly be easy, but can turn difficult. Better to do fiber optic for parapharyngeal mice, correct. Another question, Rakesh, you can add to whatever, whichever thing you would like to. And another question is, ma'am, what is the plan for intubation for a case of CA base of tongue? So
what is the plan for CA base of tongue?
Yeah.
See, again, I would say that go through the imaging properly, discuss with your surgeon. And if you feel that fiber optic intubation, awake fiber optic is definitely plan A. In case if this base of tongue tumors are known to bleed. So if you're having difficulty when you're doing a fiber optic, aware fiber optic, because it has touched the tumor or the tumor is fragile, if a part of the tumor has dislodged into your this one, so that turns the entire situation into a difficulty with where you lose the control over the airway when you're attempting fiber optics. The fiber optic can be done successfully in case if we are not able to do it because of the huge fragile mass. And if there is any obstruction, then we have to go for front of neck access.
So what I would like to add is that in literature, there is nothing which is told, like I'm sure we all are onco-anesthetists and all of us are doing so much of base of tongues, but it's not all the base of tongues we do fiber optic. But for the students, I would say base of tongue is synonymous with fiber optic. But yes, we in so many years, we follow some small criteria with the surgeons, like if more than 1/3 of base of tongue is involved, we don't attempt. As you all know that the base of tongue is at the valvular level, that is where we put our scope. So both the things can happen, bleeding can happen, plus we may not be able to put the scope there and bleeding starts. So ideally would be fiber optic. Chexoscopy is always for surgeon or for anesthetists who've been doing such cases from a long time. They can decide. And then fiber optic. Rakesh, Anjali, Jyotsna ma'am, would you like to add? Because everybody does in a very different way base of tongue. And I tried to do a study, but I couldn't come up in literature anywhere where there is a standard thing for base of tongue. So it always says fiber optic. Anybody?
I agree.
I would like to add one thing, ma'am.
Yeah.
So as I've already mentioned in the presentation, like submandibular space compliance would be definitely compromised in these patients. So assessment of the submandibular compliance and submandibular space
Definitely.
also is
important. Yes, Anjali, you wanted to say something.
See, what I think is the discriminatory point is the ankyloglossia. Is the patient able to protrude the tongue or not, or is the base of the tongue fixed? Once the base of the tongue is fixed, it is difficult to expose the larynx by doing a laryngoscopy. So in these patients, you should definitely go in for a fiber optic. That would be the point that you would take. And as Namrata already said, it is important to note that you should see, I always feel that a fiber optic should be a plan A, because if something bleeds, then everything becomes more difficult. The light is absorbed by the blood. You cannot visualize anything. So I think you should go with your plan A for fiber optic. The other thing is post-radiation therapy. There again, your glottis cannot be exposed because everything is one mass, you cannot expose the glottis. So that is important. Rakesh, you wanted to add to this?
Something I think you both have nicely summarized. Fiber optic remains the standard technique. But at times people have started using the hybrid techniques. And the reason is for hybrid techniques is basically when we do a fiber optic, it still remains blind in the oral cavity. We are able to see the trachea carina, but when you railroad the tube over it, if it is a friable tumor or it is a cystic lesion, then by the tube tip, those damage can happen. And people have started looking for whether this also can be visualized, which is not feasible with fiber optic bronchoscope, especially with railroading of tube. So that's why some people do video laryngoscopy. They say it's an epiglotoscopy, and they try to visualize that the tube goes unobstructed into the path without causing much damage. And this is one of the important aspects for any tumor surgeries, that we should not be breaching the anatomical site or anatomical path, so that we are not leading to the tumor settling. So this is an important aspect, because if you have some blunt trauma, the tumor of base of tongue, and it goes along with the tube into the trachea, the settling can happen sometimes. So this is a little concern people are looking for, even for the regional nerve blocks for the topicalization of anesthesia, and same would be applicable. So this is emerging. I do not have evidence for it, whether it protects or not. But this, yes, one is the modality which many people are doing it, including us.
So, but I have this thing, see, basically when we are using a hybrid technique, the whole idea behind is that with the video laryngoscope, we are seeing the glottic area, glottic and supraglottic area. With the fiber optic, we are seeing beyond the glottis. So the advantage we have only in the tumors where it is glottic or supraglottic, because when you are seeing with video laryngoscope and when you are pushing the tube, you don't want that tumor around the glottis to be disrupted. But in these kind of cases where the tumors are here, those hybrid techniques will not help. That is what so I would prefer in a like we use, and it's not an easy thing to do hybrid, because you require 2 operators, 2 monitors. It is, all of us are doing it, but I think in oral cancers the advantage is less than as it will be in glottic, periglottic or subglottic tumors. Do you have anything to add to it, Rakesh?
Nothing, ma'am. You have summarized it nicely.
So
I just want to add something. Karthik has also asked a question. How common is the dual technique undertaken and FOB video laryngoscopy? And this sort of melts with the question that Vibha had asked earlier, what about parapharyngeal tumors? So what happens, I think, is when you have a parapharyngeal tumor, recently we had a vallecular growth, and you simply with the fiber optic could not visualize the larynx at all because it was falling over. So there it helped, to pick up the tumor with a video laryngoscope. Of course, the patient had very good mouth opening. The constraint in oral cancers is when you have trismus, you are not really able to insert a of course, video laryngoscopes come with different profiles. So, we have scope where the blades are disposable and the profile is very narrow. So those sort of video laryngoscopes are particularly suited for these oral cancer things, I feel. So as Rakesh has already said, what happens is you get a much wider field of vision, which you're not getting with the fiber optic. So I think that is where this comes in. And as already pointed out, if there is a fragile growth, you get bleeding. But even if you don't have a fragile growth, the restraint is that the larynx is fixed. One other thing I just wanted to mention is in case 1, when you were discussing with the nasopharyngeal airway, that's a very good technique. The other thing to do, you suggested that we pass a bougie or an RT. So I tend to do this as an elective thing for everyone. The advantage being, if your mouth opening is good and you can visualize the bougie in the first instance, you do not get a submucosal passage. So if you visualize the bougie and then railroad your tube, you can of course remove the bougie and do the rest as usual. But I think these are little tips and tricks. If anybody can add, then we all learn from it.
That's absolutely good. And so because bougies were not used before, they were because used to be really stiff. So initially we didn't have bougies when we started, some say 15 years ago. So we were using the Riles tube. So that time bougies were not there only. So we were using Riles tube. We would cut the Riles tube, railroad the tube over the Riles tube once we see the tube is inside Riles tube. So that's how we were 90% we were able to railroad with the Riles tube. Now we people are also using the bougies, but your idea is very good, Anjali, that from the beginning only if you can start, you can just put it and then you will not have a false passage at all. That's a very good tip. Okay, let me go through the next question. How common is dual technique undertaken like FOB plus video laryngoscopy, because we could not be able to see the tube passage through glottis during fiber optic alone?
Yeah, we took that.
Yes. Okay.
The next one.
Post-operative bleeding is always a nightmare. What is your approach in anesthetizing such patients? Rashmi, would you like to take? Or
Yes, ma'am. See, this I mentioned in the presentation. Like post-operative bleeding is an expected complication in oral cancer, especially when they're having a huge flaps. So our institutional practice is to keep the endotracheal tube in situ for till next day morning. We allow the patient to be shifted to ICU with the endotracheal tube in situ, and patient will be spontaneously breathing. We connect the patient to the TPs and we sedate in case required and oxygenate the patient, humidify and do all the ET tube care. So such patient, if they're bleeding, we will immediately shift the patient, and we have already ET tube in situ. We need not have to worry about how to anesthetize because we are just going to give either IV induction agent or depending on the patient's vitals and put the patient on ventilator. I mean, that is how, because airway is already secured. In case if your airway is not secured, so then again, considering that your direct laryngoscopy may affect the surgical site, it may give stress on the surgical incision, I mean the that suture line. Better would be to go for upfront tracheostomy.
or somebody would go for fiber optic?
I don't want to go to fiber optic in this case because post-op bleeding may be an emergency case where fiber optic would require some time to prepare the patient, and we do not know if we have that much time to do a fiber optic in this case.
Anything, Rakesh and Anjali, do you differ on this?
Yeah, I would say I would definitely go for an awake fiber optic. So Vibha's question is in a patient where the airway is not managed. Yeah. So when your airway is not managed, you have bleeding and you anesthetize the patient. The bleeding will track down into the trachea. The thing about blood in the airway, it is the worst thing to have in the airway because it clots. Other fluids do not clot. If they clot, they form a ribbon. Have you ever removed that from the endotracheal tube? After passing, a lot of us may have. So in a patient with a bleeding in the airway, do not anesthetize the patient. Always go for a fiber optic. The problem here, of course, is the bleeding makes things a little bit more difficult. But it's always better to have a Yonker suction, large catheter, red rubber catheter. So you need 2 suctions, one on the fiber optic scope and one which somebody else is assisting you from the other side, from the oral cavity. Only then will you if there is catastrophic bleeding, that is one way of preserving some area of sight. If all of this is impossible, then of course a rescue tracheostomy would be what you would need to do. But I think it is worth doing this.
So why don't you prefer upfront tracheostomy, then waiting for rescue? You will weigh the pros and cons, Anjali?
See, tracheostomy, if it is life-saving, we have no alternative. But tracheostomy itself carries a lot of morbidity in the post-operative period, which we do not see. Okay. So for the patient, it is not the best of alternatives. If it is life-saving, there are no two ways about it. You just go for the tracheostomy. You need to have computer surgeons who are able to do a rapid tracheostomy as well, which most people will in an oral cancer institute. But that is subject to, I mean, sometimes you may not have those people on campus. The patient may bleed in the night. You may be the best rescue that the patient has. So if you are capable of doing a fiber optic, nothing like it.
Because that time so it all depends, I would say, the kind of institute you have, the expertise you have, and the kind of flap and what surgery was done, which was, so we cannot give a message of just doing fiber optic or tracheostomy. It exactly will depend on the type of surgery and which and where the bleeding was occurring. Okay, the next question is from Rakesh. I think Rakesh only will answer. How to exchange the tube if tube cuff ruptures while inserting in such a difficult airway? Rashmi, take this.
So most of the times we will get to know that the tube is ruptured only after the tube is in place. And when we try to inflate it and connect it to the monitor, then we realize that the tube is punctured. So in a way that we are already safe because our tube is already in the glottis, what we do is we put an airway exchange catheter through the tube and take the nasal or whatever the ET tube with the punctured cuff outside and railroad a new endotracheal tube through that. So that would be a safe technique to exchange the tube because we are already in the glottis.
I think that answers, or anything else, Rakesh?
Perfect. Absolutely. I think people should be aware of, because sometimes they have turbinates and concars, so tube rupture can happen. So airway exchange catheter should be there while you are putting it up in a difficult airway. I think this is a rescue. And herein again, when you change the tube, I would still say that a hybrid technique, because radial laryngoscope is available. So during exchange, you can just insert it, so it goes. That's it.
And definitely under vision of a video laryngoscope, doing all these procedures would be definitely a plus.
So one thing that I would like to say about this point, why did your cuff rupture? Was it because of your maggots, or was it because of a tight fit to the internal layers? Okay, so if you had a tight fit the first time, you're going to have a tight fit the next time. So it might be better to utilize the other nostril, pass your fiber optic, visualize, then remove the first tube and walk in. Or if there is, as Rakesh said, an alternative to a combined thing, video laryngoscopy as well as this, then that would be the best. But you might utilize the other nostril.
That's a good point. So the next question is, what precautions and management for accidental extubation during surgery and prior to extubation or during transfer, as these patients require elective ventilation?
So, ma'am, sir, do you mean by asking elective ventilation that the patient will be put on ventilator, sir?
Again, sometimes they are being shifted from OT to ICU, and on the way there could be an accidental extubation sometimes, like, but it gets entangled with something during shifting of patient from OT table to the transfer trolley. So what precautions?
I understand this question. Yes, sir. So there are two possibilities in this scenario, sir, where routinely your patient has come out of your neuromuscular blockade. We have reversed him well. We are still keeping the tube in situ, where the tube has got extubated accidentally. The other thing is, if your patient is deep and your patient is not breathing spontaneously. So there are two scenarios which can happen. In the first case, where the tube is extubated in a reversed patient, we have some time to secure the airway. Because your patient is spontaneously breathing, your patient is reversed. But depending again on the surgery, what the patient has underwent, and if the patient has underwent a bulky tumor, I mean, the bulky flap is there, where you do not have much time for fiber optic, because again, why we are keeping the tube is because surgical airway, the surgical procedure is causing so much airway edema that patient may not be able to ventilate without the help of the tube. So we want to keep the tube so that we are giving time for the edema to resolve. In such case, the option would be to, if the patient has already started desaturating, again, I would say that front of neck access surgical airway is the option. But in a reversed patient who is spontaneously breathing, we have time where the flap is not very thick. Fiber optic can still be used in that patient to secure the airway. And in the third case where the patient is not reversed out of the neuromuscular blockade, I don't think we have too much time. So video laryngoscope again can be tried in that patient if it is not a contraindicated to quickly. The fiber optic main drawback is it takes time, whereas video laryngoscope quickly it can be done and airway can be secured is an option. And if video laryngoscope cannot be done because of surgical procedures, again, surgical airway would be the option.
So Rakesh, you have a particular thing in your mind when you are asking what precaution you should say. So kindly answer the question.
I just feel that it's just not the intubation, because we have emphasized and Dr. Rashmi has already mentioned about the extubation. We should be very cautious when these patients are shifted from one place to other at the end of surgery, because these patients may be done or finishing up maybe second case by 5-6 p.m. Everybody is in a hurry. We do not have a difficult airway cart. And the initial technique that we do, we can open the mouth, we can extend it, everything is fine. But when the flap is in situ, you cannot put a lot of pressures because the flap can be damaged. If it is a vascular flap, the surgeons will be too concerned. They will not allow you to open the mouth. Even the video laryngoscope, though the mouth opening would be there, but they will not allow you to use it very comfortably, because there will be a little concerns of damage of the flaps that can happen sometimes. Even those who are closectomies, now they are putting up vascular flaps. So we have to be cautious. On the other hand, when we say the fiber optic is the standard, but in these patients, fiber optic is not the standard when something is bleeding, because you will not be able to visualize anything. So it's not for a bleeding patient. So if it is by something happens and bleed starts happening, the fiber optic is also gone away. So that's why I put the word precaution first, that this scenario should not happen. Be cautious. One person should be at the hand, holding the tube nicely throughout the procedure, throughout the transfer, till the patient is shifted back onto the ICU bed and stabilized. So I think precaution is much better here than securing a made more difficult during extubation scenario.
Yeah, I think disconnection is the most important thing. You disconnect your tube, don't shift with your tube. I think that is the first thing that you're taught when you start doing these cases. So this is a very important point that Rakesh has brought up really. I don't know what everybody's experience is, but these Romson's tubes, the material is so bad. I've had a cuff come off when trying to stick the tube back in again.
I think I'll stop you here. I'll stop you here. We should not be commenting on this academic platform for a particular tube. Let's hear the person.
My apologies. So you need to keep a watch on that as well, because I've had a cough go at that. The other thing I wanted to say is there are lots of very interesting questions that are coming up from the audience. Perhaps this is a topic for a webinar or a seminar rather than a lecture, but there is an interesting question from Arghya. Choice of intubation for bleeding thyroid with panicky surgery.
I think, Anjali, we should take it when we are doing thyroid webinar.
Perhaps, yes. I think we are running out of time.
No, so there's just one more question. Doctor, somebody has asked, are we running out of time? We can tell me.
Well, not really. We can
take relevant to oral cancers. Okay, so one is, what is the best way of anesthetizing nose and nasopharynx? Jelly through the nose may make FOB intubation hazy. Rashmi, would you like to?
Ma'am, I would say that jelly, we will put generally in our practice that we put oxymetazoline drops for vasoconstriction followed by jelly. So jelly do not actually come in the way of fiber optic intubation, because we routinely use it, and I think all of us also routinely use it. And after you have put nasal jelly and you give adequate time for the patient, we put a nasal airway through the passage, which clears the nasal passage of the jelly, which is going to cause any haziness in the fiber optic on the fiber optic scope. So far we have not come across any haziness because of the jelly per se. But alternate routes can be an atomizer where we spray into the nasal cavity and into the oropharynx, where atomizer gives really smaller molecules of the local anesthetic and causes better airway block. I mean the blockade of the nerve endings in any of the places where we atomize.
Even nasal packs are being used by people. So anything else, Rakesh or Anjali, do you do for your nasal preparation?
Using jelly is not a big issue, and most of when patient sniffs in, it gets cleared up. So I don't think there is any issues as such for using jelly or localizing, and even it acts both the purpose. It's topicalized also and lubricates.
I have also used it all these years and never had this problem.
So Dr. Kalpana has a question. I think she means extubate. It's written you extubate, patient coughs, and there is a big pool of blood spat out. Patient starts desaturating. Now what?
Sorry, ma'am, I didn't get the question. I can't see the questions actually.
Actually, you open that question and answer thing, Rashmi, down on where you were sharing screen.
No, so far I was able to see this particular question which you read out. I cannot see it on the screen.
Okay, so see, it is you extubate, patient coughs,
Mm-hmm.
and there is big pool of blood spat out. Patient starts desaturating.
Yeah.
So though condition once, it either can be on OT or in ICU.
So yeah. See, considering that we are keeping the tube for till next day morning, where the edema and all would have come down drastically, and patient is spontaneously breathing, that is when we are taking a call on extubation in these patients. So we are routinely doing these cases, generally 5 to 6 cases in a day we do, where we keep the tube and extubate the patient next day morning without airway exchange catheter, because we assume that we have given adequate time for edema to settle, and patient has not had any problems when we extubate this patient next day morning. When we are extubating, as it has been told that if the patient bleeds, which means that patient is fully awake and he is having all his reflexes intact. So there are less chances that we need to panic in this situation. So in case if it is panicking situation, it could be basically because of the apprehension of the patient, where we need to reassure the patient, and maybe you give little head low and suck out the pool of the blood which is there in the throat. And only if in case, as it has been told that patient has started desaturating, which means that patient has aspirated, could be because his airway reflexes were not intact. In that situation, I think to secure the airway, best option would be a surgical airway.
Anything you want to add, Anjali and Rakesh? I know she will suck it nicely. Try to visualize and then make your plan. Anjali, Rakesh, what would be your choice?
Yeah, I think Rashmi Madam has already mentioned it nicely, Madam. These things can happen, and that's why at times, though people used to use a word, smooth extubation or gentle extubation, but my teacher used to say that all extubation should be gentle, not for difficult airways. So that's a normal thing. So I should not be emphasizing on it. It should not be a stormy extubation or something like this. Second thing is, sometimes if there is something sitting on the glottic opening, if there is a mucus there, and if you extubate it, that irritates and causes a cough. And since we already talked about, sometimes there could be a borderline anastomosis or a borderline graft, and they can bleed sometime. So it has to be a very controlled way. And majority of time, I don't think they would require sedation or something. A good patient counseling, a good suction is sufficient enough to get cooperation from these patients, because I would not suggest that give them a midazolam or dexmedetomidine at this point of time. This is not suggested, but I think counseling is one of the important aspects that we can go ahead.
I think I would say one thing. The patient has a good cough. He managed to bring something out, right? So let's not dampen it by giving sedation. The other thing is, we are all talking about intubation. It is a mask ventilation that is a very crucial thing in these cases. You could give oxygen, hold oxygen, mask ventilate, see that the saturation comes up unless the patient has aspirated a huge amount of blood. That may help as well.
Sometimes
trying to get the saturation to 100% is a priority over trying to manage the airway. That is what I'm trying to say.
And sometimes just the suction may help. Sometimes just the suction may help with oxygenation. That's all correct, Anjali. So we are touching 7:30. A comment by Dr. Indra that simple precaution of suturing the nasal endotracheal tube to the nares help in preventing accidental extubation. How many of you follow this?
So there is evidence. I have never sutured an endotracheal tube, but there was a practice earlier of suturing the RT in by the surgeons, and that used to cause necrosis of the columella. So that is no longer practiced. So I think that is, I mean, I don't know how many institutes actually do that.
Even we don't follow. Even if the plasters are not put properly or too much tightly they are put, the chances of necrosis are much, much higher. So that needs to be taken care of. Yes, we do suture the, in Whitefield laryngectomies are flexometallic tubes,
Yeah.
but not the nasal tubes. Okay. Now, another question is, are commercial lignocaine atomizers available in India? Yes, they are. And the best one would be to make your own by using a cannula connected to the oxygen and with a three-way cannula. And then from this side, you can give lignocaine. The spray would be beautiful and much better than that expensive atomizer, which is available. Rakesh and Anjali, do you use the atomizers?
Yes, sometimes we have used it, but I think spray as you go technique is equally good. So that works. And yes, as you rightly said, people have used with oxygen influx into it at 5 liters, it just atomizes something. But yes, commercial atomizers are also available and they're cheap one.
And the another thing is that when you're doing awake video laryngoscopy is when these atomizers are very important, because it is a similar thing you can do for awake video laryngoscopy and fiber optic, but it is the gag reflex which we need to avoid in video laryngoscopy. This is where these atomizers help us, which can, you know, spray at a little longer distance. So just from the angle of the mouth, if you spray with this handmade, I mean the cheap atomizer, which I'm talking about, 20 gauge cannula with the three-way, it really, really helps. Another comment by Dr. Sukhdev sir is, I differ about the jelly, spray and nebulizer are better. That is according to whoever does, like how Rashmi mentioned that we can use the spray and nebulizer are also good. Dr. Indra says, do you routinely give prophylactic steroids to reduce edema? If so, for how long? We don't give routinely. What
Neither
about you, Rakesh and Anjali?
Neither do we. We don't use steroids.
Rakesh?
So I think this is not a routine one. And when we were developing our extubation guidelines, so we have looked for this evidence also, and we have put it there also. So whatever said, people still use it. So I don't think there is any harm of giving a single shot steroid of hydrocortisone 50 or 100 milligram once a time. But we need to understand that what type of edema it is. Steroid is applicable for only the inflammatory edema. In majority of these surgeries that we do, it is the vascular or lymphatic edema, where steroids does not have a role. So if you think a multiple handling has happened during the initial airway management, it is a small surgical procedure. And because of a traumatic edema, which is almost equivalent to inflammatory edema, you can give it. But in majority of patients, these patients will end up because of the vascular congestions and lymphatic, because lymph nodes are usually dissected for these patients, and there will be less of the lymphatic drainage. And steroids does not have a role into it. So now this depends upon your case, whether to choose or not, depend upon the etiology. Similarly, I'll just add on, people have also tried to use the nebulized adrenaline at the time of extubation. Still, though evidence is not there, but the extubation guidelines say that if patient does not have contraindication, you can use the external nebulization of the normal ADR we have. Probably it may help, but I agree, there is no evidence for both of those things.
Okay, so before we wind up, Argya, we will be taking the thyroid questions in thyroid webinar. And the last question with free flap, Anjali, we have a webinar on free flap also, right?
We will, yes. But
Yes,
I think
we will.
maybe you could just give them a one-line answer. Do you prefer tracheostomy after treat?
It's not in all of them. It again depends what kind of flap was done and what kind of case and what type of surgeon also.
Perfect.
Okay. So I think we should wind up the session, and I would just conclude by saying that no patient is the same. Always be ready. Plan ABC always is for the students, that make sure you, even if your senior is not with you in the operation theater, you inform that you are dealing with a difficult airway, so that if any call goes to them, they are there when required. Preparation is the utmost thing. And remember that when we are doing intubation, always people are there, gadgets are there enough. But when we are doing extubation, things are taken lightly. And in my experience of 27 years, very few, whatever complications I have seen them in ICU rather than inside the operation theater. So I think we should call it a day, Anjali and Rakesh and Rashmi. Rashmi, thank you for such a comprehensive, like, I think 1 hour on oral cancer, and still there was so much to do. It's more than, we have passed 7:30. So
Thank you, ma'am. Thank you so much.
thank you, everyone.
Thank you. Thank you, sir. Thank you, Anjali, ma'am.
Just say Rashmi did a wonderful job. And the
Thank
only
you.
thing I want to say to the audience is please remember the oxygenation before you
Yes.
think about the other things. Thank
Yes,
you.
yes. Tips from, I mean, this is just to, if I keep on saying, I had to put a line of what all to do. Okay. Theek hai.
Well, that
Thank
was
you.
awesome. Awesome. Very good. Thanks.
Thank
Good night.
you. Thank you. Good night, everyone. Bye-bye.
Thank you everyone for sharing such valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for our next sessions. With all your permission, I would like to sign off for today. Thank you so much, everyone.
Bye-bye. Good
Thank
night.
you. Thank you.